Our first speaker is Dr. Aysha PAP. She is the consultant cornea and refractive surgeon at Srikanth Eye Care Hospital, Calicut. She will be talking about recurrent corneal erosion and overview.
Good afternoon. So I will be mainly talking about the recurrent corneal erosion. So recurrent corneal erosion of the corneal epithelium is a clinical syndrome of multiple etiologies characterized by inadequate epithelial stromal attachment resulting in episodic disc adhesion and defects of corneal epithelium. It can be seen in all the ages, but few of the studies have suggested that it's seen in the mid-5th decade with slight female predominance. So what is the pathogenesis? So normal corneal epithelium, it's firmly adherent to the underlying Bowman's membrane and stroma by specialized attachment complex. This attachment complex mainly consists of a hemidesmosome and an adhesion molecule called integrate. Sometimes and ankyrin fibrils of type 7 collagen secreted by the basal cell. So hemidesmosome, integrin and type 7 collagen forms this adhesion molecule. So whenever there is a break or whenever there is an injury, whenever there is a break, there is no epithelial adhesion molecule. The first picture you can see that's a normal cornea. In the second picture there is no adhesion molecule. So this is the main cause of the recurrent corneal erosion. So there is also increased activity of MM2 and MMP2 and MMP9 in the recurrent corneal erosion. Coming to the etiology, I have classified into primary basement membrane complex or intrinsic factor, that is anterior basement membrane dystrophy like a MAP dot, Kogan, Rees, Beckler. Stromal dystrophy, common one is the lattice and second one is the macula. Coming to the secondary basement membrane complex or extrinsic factor, trauma, which is the most common one, Salzmann nodular degeneration, hepatic infection, MGD, keratoconjunctivitis sicca, diabetes mellitus, and most commonly in the post-LASIK. So why REC on waking up from sleep? Most of the patient comes and say, I had severe pain, I'm not able to open the eyes during my waking of the sleep. The main pathogenesis here is the evaporation of the tears, which causes hypertony and epithelial edema and leading to the epithelial separation. Or else we can say there is a surface saturation causing adherence between the lids and epithelium. This causes a shearing force between the lids and the corneal epithelium, finally leading to the epithelial avulsion. So whenever the patient comes to our OPD and say, this is my symptom, always explain to this patient, this is what happening in her eye, this is why you are getting a epithelial defect. Coming to the workup and diagnosis. Take a proper history, because half of the patients who are above 50 or 60, they sometimes forget there was a trauma before during childhood and everything. There will be sudden onset of pain, redness, photophobia, tearing and difficulty to open the eyes, especially during the sleep. On slit lamp examination, you can see varies from loosely adherent and elevated ragged grayish areas of epithelium. Sometimes if the patient comes after 2 to 3 days, you can see a stromal infiltrate. Sometimes patient won't have any signs or a symptom. They say, I have a few watering when I look into the light. So best thing is an adhesion test. By using dry cellulose surgical sponge, rub gently and tangentially over the suspected area after topically anesthetizing the cornea. If it is a movable, that is a positive adhesion test. That means there is a lack of stromal adhesion. If patient is not saying any history of trauma or anything, I have a recurrent episode of erosion, always examine the fellow eye to see any sort of dystrophy, epithelial dystrophy. So the first picture you can see the ragged and grayish appearance of the epithelium, and the second picture intraepithelial whitish dot. If you have a dot, stain, you can see either pooling of the stain or you can see a large epithelial breakdown. Chandler has classified this recurrent corneal erosion into two forms. One is a microform, always symptom persists only for hours and the size of the epithelial defect will be small, which causes maybe spontaneous erosion or epithelial basement dystrophy, and the frequency will be more when compared to the other, but severity is less. Whereas the macroform, the persisting of the pain or the signs and symptoms will be last for 1 to 21 days. Size of the epithelial defect will be large, break with surrounding loose adherent epithelium, and the most of the time the cause will be trauma. And the severity is more when compared to the microform. The A and B is the picture. You can see the macroform where is a large epithelial defect. And when C and D when compared, you can see it is a smaller one. So what are the management? A primary goal should be always to facilitate rapid re-epithelialization and to relieve the acute symptom. A secondary goal should be to increase the adhesion complex and promoting fibrosis. So the first medical management, always the conservative one. Explain to the patient the pathogenesis, everything, and tell the patient, don't open your eyes suddenly. Tell them to move slowly before opening, either up and down or lateral or medially. Patching, cycloplegic, topical lubricants and antibiotic are the second choice. You can also think about the BCL for 4 to 6 weeks. Tetracycline and doxycycline to reduce the inflammation, and sodium chloride. I have made it in a chart to describe what are the medical management. Always use preservative-free artificial tears. It is indicated in acute attack and also in the chronic episode, and also it can be given as a prophylactically. Oral NSAIDs or cycloplegic also you can use as a home atropine, mainly to release pain relief, and it also can be given in the acute attack. Antibiotic, if you suspect any infection, only start antibiotic, which is a cornea friendly like a chloramphenicol, or if you have any suspect of stromal infiltrate, you can directly give for fluoroquinolones. It can be given in the acute attack but not for the prophylactic purpose. Night ointment, two options we have, either Panthenol ointment we can give for the long-term lubrication, or you can use hypertonic sodium chloride, because I have already explained there will be hypotonic. So to reduce that edema, you can use hypertonic sodium chloride. Punctal block, in severe cases, if there is a severe dry eye, you can use collagen or a silicone plug. Soft BCL, if patient is not relieved with any medical management. Tetracycline, doxycycline. Topical steroid, very low potent steroid if the failed lubrication, if there is a severe inflammation. So what are the other management? The surgical management which you can do in the OPD base itself is a small epithelial debridement. What it does, it removes devitalized and debris adherent to the basement membrane. This forms a tight epithelial stromal adhesion. Always use a sterile Wechsel sponge. Next comes the anterior stromal puncture. This enhances the epithelial adhesion to the basement membrane by scar formation. You can make a multiple superficial puncture consistent depth are placed approximately 0.5 mm apart. Always avoid the visual axis. This treatment includes the defective zone, and also you can extend to at least 1 mm in the normal epithelium. Or we can use short pulse Nd:YAG lasers also. Energy level can be kept between 1.8 and 2 mm. Always focus at the basement membrane zone after the epithelial debridement. The picture you can see, we are using the needle, and you can do under the slit lamp, or also you can do in the theatre. Next comes the phototherapeutic keratectomy. Here excimer laser is being used and partial ablation of the Bowman's layer, which gives a smooth bed for migration of the epithelium and results in new hemidesmosomal adhesion complex. The ideal candidates are erosion in multiple area, moderate to severe ABM with decreased vision, loose sheets of epithelium. And the most important one, which is cheap, is the diamond burr polishing. While doing this, a smooth surface for which epithelial cells can glide and can form a new adhesion complex. This is less expensive, less haze when compared to the other stromal puncture and PTK, and you can do the retreatment also. Indication is same as that of the PTK. So small video. Yeah. Sound, you reduce the volume, I don't know. So this is the diamond burr polishing. You first, after taking the epithelium of the 8 mm, start doing the diamond burr. You can do it in the circular manner. Polish where you have to always know which is the site. If it is inferior, if it is a superior, a little bit of concentration you can give in the site area. Put a BCL, antibiotic, and you can give also a low potent steroid for 1 to 2 weeks. So other points are the complications for the more of the recurrent erosion is ulcer, uveitis and stromal scarring. This REC is relatively contraindication to LASIK because of high risk of DLK due to spontaneous intraoperative erosion. A patient with corneal erosion with more than 2 weeks should be suspected as a persistent epithelial defect and should be dealt very aggressively. Thank you.